Right, good morning, everyone, and thank you for joining us today for our webinar on COVID-19, mental health, and substance use in rural and remote communities. I see people are slowly filtering in here, so we just wanted to get started, and thank you for your time. Before we get into our presentations, just wanted to do an acknowledgement that I am on the unceded territory of the Okanagan Nation here. And as we go through our presentations today, just wanting to think about the inequitable impacts of the health topics that we're discussing today on the Indigenous populations here in Canada, and especially with the amount of Indigenous populations living in rural and remote communities. It's definitely very relevant considerations for when we're working with those communities, collaborating with those communities. So just thinking about what that means for you in your work wherever you are today. And if folks wouldn't mind just popping in the chat the unceded territory that you're joining us from today, there should be a link coming in the chat that will show you how you can find out the unceded territory you're on if you're not familiar with that. So it's a really handy kind of interactive map that we'll share with you there. So yeah, I'll introduce myself as well here. So my name is Lauren Erth, and I'm a registered nurse specialized in mental health and substance use. And I graduated with my Master's of Science in Nursing in 2019 with a focus on rural older adults' mental health. And I'm currently a campus health specialist at UBC Okanagan. And I'm also a doctoral student in nursing here, where I'm studying harm reduction interventions for substance use concerns. A little bit about today for just kind of a tech overview. All of you should already be on mute with your cameras off. That kind of just happens automatically when you pop in. We have a really great team helping us here with all the tech things today. And they're going to show just a quick video here of how you can switch between French language slides and English language slides. So depending on where you're joining us from today, what you're comfortable with, you have two options. So you'll see you can kind of switch back and forth as they're showing you. This is a slide from a different presentation, so don't worry, you're still in the presentation about COVID-19, mental health, substance use, rural communities. But just wanted to show everyone how that works so that you can switch as needed. Thank you, folks, for sharing that. If you have questions throughout the presentations today, you'll notice in the bottom bar of your screen, there's a little button that says Q&A. You can just click in there, submit your questions, and we're going to have about a 20-minute question and answer period at the end of this presentation. So we'll have those all lined up ready to go then, and we'll get through as many of the questions as we can. If we're unable to, I believe our presenters will be sharing their contact information and some follow-up kind of information if you want to get in touch with folks directly. So thank you again for joining us today, and I'm going to pass it over to Katerina, who's going to share a little bit about the policy brief that this webinar was inspired by, essentially. So over to you, Katerina.
Hi. Thank you so much, Lauren. My name is Katerina, and I'm a policy analyst at the Mental Health Commission in Canada. I will just share my screen. Thank you so much for joining us today. I'll just be giving a brief overview of the policy brief we published last fall on the impact of COVID-19 on mental health and substance use in Canada. And it is what kind of prompted the webinar. First, I want to acknowledge that The Mental Health Commission of Canada operates primarily on the unceded traditional territory of the Anishinaabe Algonquin Nation, whose presence here reaches back to time immemorial. And I am very grateful to live and learn and work on this territory. Just a quick plug about the Mental Health Commission of Canada, if you're unfamiliar. It's a national nonprofit organization running since 2007. The MHCC throughout the pandemic has been developing policy resources and offering evidence-based briefs, webinars, and reports in partnership with various organizations, just trying to bring policy attention to the impacts of the pandemic on mental health and substance use health across Canada. And you can follow the link on the bottom of the slide to go to our policy hub, and I'll link it after my presentation in the chat for you. So the policy brief was published last fall in partnership with Dr. Nellie Olkey and Lauren, who is the moderator for the webinar today. It builds on a preliminary scan the commission completed at the beginning of the pandemic, includes an updated literature review, a section on social determinants of health, domestic and international policy responses, and policy recommendations. It also includes a case study that highlights the community of Princeton, BC, in collaboration with the Princeton Community Health Table. It focuses on the unique impacts of the pandemic on mental health and substance use in rural and remote communities. And some of the key considerations I'll go over today. The key considerations were developed through analysis of available literature and some expert review, and they don't necessarily apply directly to all rural and remote communities in Canada, but as each community has their own concerns, but they there are some themes that ran across that we wanted to highlight. So the first was isolation, and we found that this differentiated across rural and remote communities, but was similar in that there were many communities facing the impact of this from COVID, and that had differential impacts as well in terms of youth reporting being affected more, as well as older adults in rural and remote communities. There was also the intersection of the pandemic with the toxic drug crisis. Some rural and remote communities disproportionately felt that impact, as well that despite advances in virtual mental health and substance use services for rural and remote communities, we found that there were several barriers reported in access to services, especially primary care, due to the growing digital divide and lack of culturally relevant care. As well, in terms of help seeking, we found that there were reports that some rural and remote communities were experiencing higher levels of stigma and increased privacy concerns when reaching out for formal mental health and substance use services, and peer support and informal as well support, such as peer support. As well, many First Nations, Inuit, and Métis live in Canada's rural and remote areas and hold unique perspectives on what is needed to address the mental health and substance use impacts of the pandemic in their communities. As well, we were able to gather some data around people who have immigrated to Canada and are living in and working in rural and remote communities, and were also disproportionately affected by COVID-19, and we gave a bit of an overview of that as well. And then in terms of the policy recommendations, we had 3 different categories of policy recommendations or themes. So the first was prioritizing rural and remote communities and strengthening partnerships. So this includes things like developing post-pandemic policies that recognize the unique mental health and substance use impacts of COVID-19 in rural and remote communities, and partnering with diverse community members, as well as strengthening partnerships that already exist between mental health and substance use sectors and policymakers serving rural and remote communities. The second was recognizing unique strengths and vulnerabilities of communities, so building on the strong foundation of community resilience that already exists, addressing the twin pandemics of opioid poisonings and COVID-19, and investing in innovative harm reduction initiatives that address rural and remote communities' unique characteristics. And then finally, in terms of supporting virtual care, ICT, and accessibility, we have adequate access to broadband internet coverage and internet communication devices to access virtual mental health and substance use services, tailoring virtual care solutions to the unique features of life in rural and remote communities, and finally, training rural and remote service providers and service users on the use of virtual technology to support their collaboration. So, yep. Thank you, and my email is everywhere, but if you don't already have it, there's my contact info if you want to reach out about the policy brief or the webinar as well. So thanks, and I hope you enjoy the webinar.
Thank you so much, Katerina. Like she was saying, if anyone would like to see that policy brief, I believe she's going to pop the link into the chat there. And I saw someone just asking about access to the presentation. This will be recorded and available on the Mental Health Commission of Canada's website, probably by about next week. So yeah, really interesting policy brief if folks have a chance to look through that if you haven't already. And now we'll have an opportunity to hear from one of the community members who helped inform that policy brief. So we are going to be joined by Ed Staples, and Ed Staples is a retired teacher living in the Tulameen Valley near Princeton, BC. He holds a Bachelor of Science from Dickinson State University and a Master of Arts from the University of Victoria. In July 2020, Edward brought together community leaders to form the Princeton Community Health Table, comprising local elected officials, healthcare professionals, interior health administrators, and community service providers. He's also a founding member and president of the BC Rural Health Network, which is dedicated to the promotion and support of health services system that improves and sustains the health and well-being of residents in rural communities. So please welcome Ed.
Yeah, hi everybody. I'm going to share my screen for you here. Just give me a second. Okay, there we go. So I'd like to begin by humbly and gratefully acknowledging that I live, work, and play on the traditional territory of the Inclapukmuk, the Silks, and the Upper Similkameen people. I'd like to tell you a little bit about where I live. Princeton is a small rural community in the southern interior of British Columbia, situated in the foothills of the Cascade Mountains at the junction of the Tulameen and Similkameen rivers. Princeton is typical of many rural communities throughout BC, with the main industries being mining, forestry, and ranching, with tourism and recreation growing significantly over the past several years. In the 2016 census, the town had a population of about 2,900 people. Like many rural communities in Canada, the biggest population in Princeton is age 50 and over. However, based on housing and service demands over the past several years, this number is expected to jump significantly in the next census. I should also point out that the age demographic is also expected to change based on increased birth rates in our community and changes in school grade levels. The largest Indigenous population is that of the First Nations, numbering 175 people. That's according to the 2016 census, making up about 63% of the total Indigenous population. At 90 people, the second largest Indigenous population is the Métis. The population of our local health area is roughly 6,100 people, served by a hospital that provides acute care, 24/7 emergency care, lab services, end-of-life palliative care, counseling, radiology, among others. Co-located at the hospital is a primary care clinic served by 5 doctors and a nurse practitioner, a long-term care facility with 37 private and semi-private rooms, and 24/7 ambulance services. So as you can see in this chart, Princeton exceeds both the provincial and local health authority prevalence rates in all areas except Alzheimer's and dementia. Of particular note is the high prevalence rate for depression and mood anxiety disorders. Our community has had more than its share of challenges over the past several years. According to the BC Coroner's report for the 2-year period of 2017 to 2019, Princeton had the highest number of illicit drug-related deaths per capita in the entire province. It's also important to note that the high number of deaths go back as far as 2015. This might be explained in part by the lack of adequate support services in rural communities like Princeton. And of course, the main thing we're focusing on in this webinar is the pandemic. And the COVID pandemic is the most obvious challenge that has affected everyone in one way or another. But on top of that, our community has experienced several other cataclysmic events. The first was the heat dome in June that left everyone scrambling to deal with the resulting emergency care that was needed. And then there were the wildfires that came dangerously close to our community and created further isolation because of highway closures and the need to stay indoors to get away from the choking smoke. The biggest natural disaster happened in November, when Princeton was hit by devastating floods, forcing hundreds of people to evacuate their home. All this added up has had a major impact on people's mental health and well-being. So I'd like to talk about the formation of the Princeton Community Health Table. This started on June 29th and 30th, when the Rural Coordination Center of BC held the BC Rural and First Nations Health and Wellness Summit. It included over 900 participants from across the province that were formed into focus groups arranged by geographic location. Each focus group was given a choice of several health-related topics that they could discuss. Nellie Olkey and I were involved in the Princeton focus group, and we chose mental health and substance use as our topic. At the end of the conference, the Princeton participants decided that there would be value in keeping our group together, and we formed the Princeton Community Health Table with the goal of improving access to mental health and substance use services for people living in Princeton and surrounding area. I'd like to also point out that our group is run entirely by volunteers who donate their time and expertise. We also operate without a budget, since we presently have no financial support. Like most rural communities in BC, and I would guess the same holds true across the province, or across the country, I should say, our mental health and substance use concerns can be summed up in one word, and that's access. Specifically, the difficulty in accessing services due to a shortage of mental health and substance use workers. This problem is magnified by other barriers that people face in accessing care. To access care, patients first need to get to their caregiver. The lack of adequate public transportation means that vulnerable populations must rely on family, friends, or volunteers to get them to the care they need. This presents a huge challenge for our community. The shift to virtual care assumes that everyone has access to internet. The reality is that many rural areas of the province lack adequate internet access, and in some cases have no service at all. In addition, vulnerable populations, seniors, homeless people, may not have access because they don't have the hardware, things like cell phones, iPads, computers, or they may lack the technical skills to use them. Accessing care away from home represents a huge financial burden for many rural patients. In research conducted by the Center for Rural Health Research at UBC, it was determined that on average, patients accessing care away from home spend over $2,000 on out-of-pocket costs. This includes paying for travel, accommodation, meals, and the loss of income. We are just beginning to understand the long-term effects of natural disasters on people's mental health in our community. We expect that once people's physical needs are taken care of, their mental health needs will become more apparent. To date, the Princeton Community Health Table has completed the following initiatives. The first was to develop and distribute a student-specific brochure that provides information on how and where to access mental health and substance use support services. We held a community webinar aimed at reducing stigma associated with mental health and substance use. We organized a speaker who gave a presentation to high school students on mental health and addictions. And most recently, we sponsored a mental health first aid course, and there are now 15 Princeton residents trained in mental health first aid. Our future plans include the undertaking a community needs assessment that will include a community mapping with the goal of identifying the gaps between needs and available services. We also plan to reopen a clubhouse, which will be a drop-in center for people dealing with mental health and substance use issues. This project will be a collaborative effort involving the mental health first aiders, Princeton Family Services Society, and the Interior Health Authority. We're also in the process of developing and distributing an adult-specific brochure containing information on how and where to access mental health and substance use support services in our community. And we're planning to organize a peer support program bringing together people with lived and living mental health substance use experience. So on behalf of the Princeton Community Health Table, Nellie and I would like to thank the organizers of this webinar for giving us the opportunity to share our story. It's our hope that our collaborative efforts will improve access to mental health and substance use services, not only in our community, but in all communities across Canada. Thank you.
Thank you so much, Ed. I think the Princeton Community Health Table is a great example of one way people can come together to support their communities. And it's been amazing to see what the health table has been able to accomplish. So I'm really glad you're able to share about some of those initiatives. Moving on to our next presenters here, we'll be hearing from Danica Ward and Brittany Howell. So Danica Ward has a degree in psychology from Memorial University of Newfoundland and a Bachelor of Social Work from the University of Manitoba. Since 2019, she's been working as a community suicide prevention coordinator for Eastern Health's Roots of Hope project on the Vernon Peninsula, where she was born and raised. Danica has a passion for suicide prevention initiatives, especially for public awareness and training campaigns geared toward reducing stigma around suicide within communities. And her co-presenter, Brittany Howell, is a policy planning and research analyst on the Vernon Peninsula with Eastern Health's Roots of Hope suicide prevention project. She's a passionate advocate for mental health who holds a degree in psychology from Carleton University, a Master of Science from Memorial University of Newfoundland. Her various research roles have focused on illness prevention, health promotion, and mental health. Brittany is especially interested in how communities can work together to promote mental health and wellness and reduce the stigma around mental health and suicide. So Danica and Brittany, you're up next.
Thank you so much, Lauren, for that wonderful introduction. I'm just going to share my screen now with everyone. All right, before we begin, we would like to thank you for allowing us the opportunity to present on the Roots of Hope Project Vernon Peninsula and the impacts that COVID-19 has had on the work that we've been able to do over the last couple of years. We acknowledge the land on which we gather as the traditional territory of the Beothuk and the ancestral homelands of the Beothuk and the Mi'kmaq peoples. So here is the Vernon Peninsula. It's named the Boot for very obvious reasons. It looks like a boot. You can travel from tip to toe and all the way back in just under 4 hours. I am centrally located on the dot next to Burin. And according to Statistics Canada in 2016, there were approximately 40 communities on the Vernon Peninsula, and we had approximately 35,000 individuals living on the Vernon Peninsula. And the median age of residents was about 50 years. So we are considered the rural Avalon, and our Roots of Hope jurisdiction covers every community from Terranceville to St. Lawrence and in between. And on the left, you can see some beautiful pictures of our peninsula. So I will pass it over to Brittany to talk about suicides in Newfoundland.
Thanks, Danica. And since COVID-19, it's been increasingly difficult to get updated statistics on mental health services, especially related to suicide. We were able to get some stats from the Provincial Mental Health Crisis Line that had found that calls to the crisis line had increased by 33% in the first 12 months following COVID-19 compared to the 12 months before it. We're still working to get these updated suicide rates, but to speak to some recent trends in suicide in Newfoundland and Labrador, a study by Pollock and colleagues in 2021 explored the suicide rate in Newfoundland versus the national average. And this was looked at from 1981 to 2018. So in this 37-year period, Canada's suicide rate declined by 24%. And in this time, Newfoundland and Labrador's suicide rate tripled from 4.6 deaths to 15.4 per 100,000, making it higher than the national average. In these more recent years, a spike in suicides also occurred on the Vernon Peninsula, making it imperative to address this issue specifically. Next slide. So the Vernon Peninsula signed on to the Mental Health Commission of Canada's Roots of Hope, and Roots of Hope is a multi-community-led project that aims to reduce the impact of suicide. We are the only site for all of Newfoundland and Labrador, and the closest being New Brunswick, which is our neighbor. And this project has 5 different pillars, so specialized supports, looking at prevention, intervention, and postvention services, mean safety, research, training and networks, and public awareness campaigns. And now we'll go back to Danica to talk about some of the strengths and challenges in these different pillars.
Thanks, Brittany. So as Brittany mentioned, there are 5 pillars of the Roots of Hope project that help drive the work that we've been able to do. And so we've highlighted some of the challenges and strengths of these pillars in relation to how COVID-19 has impacted that work. So under the specialized supports, one of the biggest challenges that we faced was COVID-19 temporarily suspending many of our in-person services. However, some of our strengths was our ability to quickly revamp a lot of the services that we offered. We were able to do a lot of virtual groups and to distribute a lot of our resources virtually. There's also an increased uptake in a lot of our community initiatives as well, so that was wonderful. Under our main safety pillar, the primary challenge was the COVID-19 and some harm reduction concerns, especially as it involved the stockpiling of drugs and alcohol. And also there were some barriers to accessing some timely means safety data. Some of our biggest strengths listed here were the creation of a number of infographics like harm reduction and suicide prevention, a presentation on alcohol use and suicide prevention, and we also had a pharmacy student present to our local coalition on prescription medication use and the relation to mental health and suicide prevention. Under our public awareness campaign, some of the biggest challenges was, of course, our inability to host in-person events. We also grappled with some technology concerns as well. However, a lot of wonderful infographics came out of this pillar, like Check on Your Buddy, which was shared on our Eastern Health social media platform over 100 times. We also created a presentation menu to help spread awareness of the services that we could offer under the Roots of Hope Burin Peninsula. Here are some other infographics that we created. The middle one was actually updated to say 5 ways to stay connected while physically distancing. And we also put up some posters, life promoting posters on our walking trails across the Burin Peninsula. So here are 2 examples of those as well. Under our training and networking pillar, of course, our challenges again were centered primarily around COVID-19 and our impacts to in-person training events. Virtual networking challenges as well was a concern, but some of the strengths, well, we had a lot of virtual webinars and we were able to reach people not only on the Burin Peninsula, but outside of the province even. And virtual options were budget friendly, and we had increased requests for a lot of our presentations. And we were very lucky to not be too heavily impacted by COVID at times, so we were able to do some in-person presentations. And now I'll pass it back to Brittany to talk about the research pillar.
Thanks again, Danica. And so speaking to research, there's a lot of different challenges, but surprising strengths as well. So the inability to meet in person definitely caused some challenges, and a lot of the people on the Burin Peninsula would prefer to have the in-person kind of interviews and surveys. But despite this, research continued on, and kind of relating to this too, there were some challenges in staff shortages due to people being pulled in so many different directions for COVID-19. So we weren't able to fully focus on this as much as we'd like to, but despite this, there was many strengths as well. So with everything going virtual, we had to kind of pivot it, but we got a great response to working virtually and online. Despite focusing on the Burin Peninsula, we even got out virtually and reached the entire province with certain workshops that we were doing. And of course, the collaboration and community building that came from working online was also a great strength. Next slide. And here's one of the examples that we got from a very recent community suicide awareness presentation. Despite all of the challenges, research and good work is still going ahead and we're getting great results. Some things to note would be that of the 21 participants who completed the pre-survey, 90% have been or have known someone to be impacted by suicide. And this presentation increased their knowledge about suicide and suicide myths. Also, 100% of those who completed the post-survey said they found the presentation helpful and would recommend it to a friend. Some of the quotes that I found stood out to me would be the ones down here below, such as, "I found out things about suicide and preventing possible suicides that I never knew before. I found this session very valuable." And other people had even mentioned that they would recommend it to everyone because the information is definitely helpful and could be shared widely. So next slide. So given all of this information, we had a few recommendations, and these are kind of for people who are also maybe doing work during the COVID-19 challenges. So as things start to open up, new challenges will begin, and I think these are still relevant to that, but one, to take advantage of some of the unique strengths and challenges that have come from connecting virtually. We are able to connect in new ways with new people easier than ever. And for those who are unable to connect this way, try to kind of figure out how to go about maybe increasing access to technologies and internet. Lastly, and very important, be patient and kind with yourself and others. Work will continue to get done, even if it's a little bit slower than usual and slower than we want. And we faced and will continue to face a lot of unpredictable challenges. So remember to be kind to yourselves throughout this process as well. Thank you.
Awesome. Thank you so much, Brittany and Danica. That was a really great presentation. I think it definitely highlighted again other ways of supporting rural community members and just looking at the statistics. I mean, we know that the mental health impacts of COVID-19 aren't going away anytime soon, and we're going to be facing a whole new round of concerns, I think, with restrictions lessening and current world events that are going to cause ongoing mental health concerns, I'm sure. So it's good to know about other resources. And I know folks are already asking in the chat if you're able to share some of those. So I don't know if you have some links you want to throw in there. We can address more of it in the Q&A session, but definitely interest, I think, in how people can support their communities through similar work. So awesome job. And next up, our last presenter is Bobby Jo Smith. So Bobby Jo is a project management professional and is the current executive director with North of Superior Counselling Programs, where she's been since May 2021, following a move from Southwestern Ontario. This organization provides mental health and addiction services for individuals across the lifespan and who are living across the rural district of Thunder Bay, an area which spans over 61,000 square kilometers. Bobby Jo has worked in the community not-for-profit sector for over 25 years, with mental health and addictions being her primary focus and passion. Bobby Jo's work in both Southwestern Ontario and Northern Ontario during COVID-19 has provided her with insight into the dramatic differences of living through COVID in more urban centers versus rural communities. So Bobby Jo, if you want to tell us more about that.
Great. Thank you so much. And thank you for the opportunity to come and share a little bit of my learnings and insights with you all today. I am just about to share my screen, and I hope all can hear me okay. I'm losing my voice a little bit. And I will apologize up front. My slides are quite text heavy. Especially observing and viewing the prior presentations, I'm reminded yet again of my need to get a little bit more creative with graphics and a little less dependent upon text in my presentations. So I currently work with, I'm hoping that you can see. So I work with North of Superior Counselling Programs. So we are a mental health and addiction service provider for individuals across the lifespan living in the rural district of Thunder Bay. That was already mentioned. We do have a mission to work together to optimize health and well-being with a view towards healthy people, resilient families, vibrant communities across the rural district of Thunder Bay. I'm also going to mention, because this is really significant and has been a real significant learning for myself since moving north to Northern Ontario, and is, I think, a real strength and a contributing factor for some of the successes that Northern Ontario has experienced, particularly through the Thunder Bay and district and the Northwestern region. Some of the successes are certainly, I think, attributed to the strong partnerships that exist within the Mental Health and Addictions Network, and also the Children and Youth Mental Health and Addiction Planning Table and Network. And I'll be speaking more to those partnerships shortly. So we are a geographic region in service, and this is an opportunity for me to also acknowledge that the area within which we fall is Robertson Superior Treaty Area and Treaty 9, which I feel so grateful to now be living and working and learning within. We're a service area that falls within Northwestern Ontario region. And we are part of the Thunder Bay District Health Unit's catchment area. Where, as mentioned previously, we are a service area that covers over 61,000 square kilometers. And in 2016, Canadian Census identified our population within the district and across this area being just over 52,000 individuals. And we as an organization have 9 offices across this district in an effort to provide as much face-to-face services as is possible. So the impact of COVID-19 and during COVID-19, certainly what was seen, and this is consistent with what you're hearing and experiencing, of course, it's not just unique to where we are, but the increased isolation on the part of individuals and families, the physical and social isolation. You'll likely recall early on in COVID, there was discussion and requirements and sort of direction to socially isolate. And very soon we realized, oh geez, we need to move away from that language and encourage physical isolation, but still encourage and try to facilitate social engagement. Of course, you know, arriving at and kind of changing that language, folks were still not only physically isolating, but socially isolating. But earlier on, certainly a greater degree of that social isolation going hand in hand with that physical isolation as well, which we needed to overcome, which you'll recall. But also with COVID-19 setting in, there was an absence of early interventions that would have typically occurred. For children and youth, those interventions often occur when those children and youth are in schools. You know, for services providers that usually enter the home for routine visits or assessments, those visits were no longer happening, so there was an absence of early interventions. And of course, with services shutting doors, including ourselves, there was an absence of greater insight and intervention when folks would because folks weren't coming into the office as frequently. There was also an avoidance of service engagement until such time that issues reached a crisis level, often resulting in the need for emergency and crisis response to what had by that point become multiple and increasingly complex issues. So whereas in the past, individuals may have engaged sooner or have had an intervention sooner because of that face-to-face engagement, that wasn't happening and hadn't been happening, and even up to recently hadn't been happening. So by the time that folks were reaching out, it was no longer one maybe relatively isolated issues. There were multiple and complex issues, not just mental health, but an addiction, but physical and really as well, behavioral as well, any number of issues. We also were seeing an increased loss of housing due to increased isolation and the avoidance of engaging in eviction prevention supports leading up to eviction processes, unfortunately. And certainly here within the district, with the recent resurgence in and opening up of mind and sort of increase in business and industry within the mining industry across the district. At the same time that folks are losing their housing, remaining housing that is available is increasing in price substantially to not only purchase but to rent as well, so resulting in additional barriers. And that's even if folks can find actual housing inventory, given the absence of the same due to the influx of newcomers to the area to take advantage of the employment opportunities through the mines. We also had across Northwestern Ontario, so this isn't specific to the district, but the Ontario Chief Coroner's report did identify that there was a 50%, if you can imagine, increase in drug-related overdose deaths across Northwestern Ontario in 2021, with 152 deaths. That averages 2 deaths every 5 days, which is incredibly alarming. So in terms of strategies to address these increasingly complex issues, which of course are further magnified by the geographic isolation which already exists, as well as, you know, the absence of transportation, all of those realities of rural and remote living. And this is where I started to see some really significant differences coming from larger urban areas, city centers, and having worked in a city center before, larger urban areas, and even more recently, prior to moving to the north, living in rural Southwestern Ontario, yet rural really not even comparable to rural Northern Ontario. There was a foundation, and there's a foundation of longstanding partnerships across the Thunder Bay and District committed to creativity, flexibility, and the sharing of resources. These solid partnerships enabled services to quickly engage with one another and strategize solutions to presenting needs in a timely manner. And I'm going to go into a little bit more depth around that partnership. It's easy to say partnership. It's easy to put on paper that there's partnerships and collaboration. But what I see here across the northern district and region goes way and far beyond what's written on paper and anything I've seen in terms of collaborations in any other region I've worked. Also drawing upon small, rural, and close-knit community members' knowledge of their neighbors to engage and support their neighbors as possible. So, you know, being in small communities is great in that you know your neighbors, but is of course sometimes challenging in that your neighbors know everything that you do. But what was really evident as well is that not only North of Superior counseling programs, but programs and services and communities across the district were really able to leverage and build upon the strengths of small communities to know their neighbors and to know when to reach out and seek supports for neighbors that perhaps weren't being seen or weren't being engaged in at the same level that they had prior to COVID. So we, like many organizations and not only across the district, but elsewhere, implemented virtual services and further increased our delivery of virtual services. Across the district as well, and the city and district, the rapid access to addiction medicine, the RAM clinics, maintained open doors, which was so critical to being available at the time that individuals in need had that need. I can't say enough about the RAM clinics and the partnerships across the district that work together to keep our RAM clinics up and running. I say they're not NOSP's RAM clinics, but they're clinics that are a result of collaborations across the area. We also made sure, as did other groups as well, that there was a graduated increase to face-to-face service delivery in alignment with provincial and district relaxing of COVID-19 restrictions. So as soon as it was possible to start offering some face-to-face, we jumped on that, recognizing, of course, the need to still ensure safety of staff as well as community, but as quickly as possible, trying to increase face-to-face both in the office as well as in the community and in individuals' homes. There was also across the district an aggressive marketing of the Lifeguard app and the Breaking Free app. These two apps, and again, this aggressive marketing effort wasn't led by our organization specifically, and these apps aren't unique to the district. They are available across Canada, but honest to goodness, I can't say enough about how impressive these apps and opportunities to educate others on these apps, how incredible it's been. And again, it just shows where across the district, the partners that are delivering services recognize that we need to get creative, we need to be flexible, and we need to implement every possible option that exists for individuals, particularly during times like COVID where folks are isolated. There is more reliance around self-management and taking advantage of realities that we know exist. And that's, of course, everyone seemingly has a cell phone in their hand. So the Lifeguard app, for those, I'll just quickly mention, for those who aren't aware, it does support individuals who are using drugs through the provision of a direct link to emergency responders if an overdose occurs. So individuals who are about to use, they activate a timer, and if that timer isn't stopped with X number of minutes and the alarm isn't responded to within an X number of minutes, a message does go to emergency medical responders. It's also a great resource for individuals and communities in that it provides updated information around such things as local supply contaminants, access, location of supervised injection sites, detox services, etc. And we were very fortunate to have an impressive leader within our network here in Thunder Bay and District, take a lead in the marketing and education around the availability of this app. Similarly, a second app, Breaking Free, it's an online program that delivers CBT for individuals with substance use disorder. Individuals can engage in self-assessment, continued self-monitoring, results and feedback can be shared with a support network. It provides calendar alerts for things like appointments or for folks to go collect their meds. It really works really nicely and goes hand in hand with ARM clinics really well. It offers things like geolocation alerts, so prompting individuals to engage in some pre-planning if they're actually quite literally physically entering a risk area or a risk situation. So again, our community partners who took a lead on bringing these apps to the area, a lot of credit goes to those folks, because then we were able to spread that and further enhance the availability of services to individuals who were perhaps isolating and not engaging with us. Of course, as previously noted, despite the fact that we were engaging and increasing in access to virtual supports, of course, there was a significant limitations in relation to access to reliable internet and communication technology across the district, or the additional financial challenges associated with increased costs for increased usage and reliance. Also, upon individuals re-engaging with services and supports and returning to school upon restrictions being lifted, many of these individuals had multiple increasingly complex issues requiring treatment, resulting in the need for a more coordinated approach to services, including the need to engage alternative service providers to address the most presenting issues. So we've certainly been finding in-house, and we're hearing from our community partners as well, that clinicians are increasingly being faced with client needs outside of their scope. So again, thank goodness for the level of collaboration and partnerships that exist and were pre-existing prior to the pandemic. But now we have to even further broaden our partnerships, given the fact that we're experiencing, folks are coming to us with issues that we haven't previously had to intervene around. As we're exiting COVID-19, we're realizing, and as we've seen for quite some time, the staff and clinician fatigue is contributing to staff departures, unfortunately. And increasingly, more and more clinicians are opting to move into employment opportunities through which they're able to work remotely. You factor both of those things into the fact that it's already challenging to recruit to rural and remote areas. We're now in a situation where, in a current state where there's an increased number of individuals re-emerging and requesting services. They're coming out of their homes quite literally. They're presenting with multiple and increasingly complex needs. The needs are now up here, yet it's at a time when we have an all-time low of qualified and existing clinical resources. It's quite challenging. So moving beyond COVID-19 and how to move forward in some learnings, I'll quickly, I'm guessing I'm coming close to my time, but-
Bobby Jo, sorry, I'm not sure if you can hear me. We may just need to wrap up here. If you,
okay.
Yeah, if you want to close up just with a few seconds here, we do
Sure.
need to jump into our Q&A.
Yeah, sure, I apologize.
Yeah.
I jumped when I heard you.
No
I'm just going to emphasize that the foundation of the longstanding partnerships allowed for the effective coordination. That's the biggest takeaway for me, is that there's partnerships in Northern Ontario recognizing the need. Partners recognize the need to do things differently where there's so limited resources and an absence of services that might exist in more urban centers. So the absence of being territorial or sort of focused on one's turf, I would say, has gone a long way to supporting the success in managing need in Northern Ontario. And again, looking for creative solutions and service providers, educating other service providers on available services and opportunities, for example, the apps, so that together we can work to meet the increasing need. Those are the biggest takeaways. Thank you.
Thank you, Bobby Jo. Sorry we had to cut that presentation there, but I think there was a lot of good information, and I think it leads really nicely into our our first question here, which is from when folks were registering. So from that question and answer sort of series, someone wants to know if some of the panelists could identify existing strategies for people here today that they might be able to integrate into their work to address the needs of clients living in rural and remote communities. So maybe I might throw it over to Brittany and Danica, if you want to offer some suggestions in a little 30-second nugget of your top 5 suggestions for how we might be able to do that from a practical standpoint.
Absolutely. Thank you, Lauren. That's a great question. And we did have this issue come up quite often because we do live in a rural community and we have a lot of people joining us from rural communities. So one of the things that we did as kind of an alternative was to offer our presentations via Zoom platform. So we could provide a call-in number. So for those individuals who didn't have internet access, they could still listen to the presentations, and then we'd send out the presentation hard copy to them via email or in the mail if they needed it. So that's one of the ways that we helped, address that issue, I guess. Thanks.
Yeah, that's a great idea with Zoom. I always forget there's the option to have a phone number or to send out a physical copy of a presentation. So that's really great to include for sure. Brittany, did you have anything to add to that?
No, I think that she answered it excellently, but also just creating resources. Me and Danica were talking about, we're always trying to create more resources, and recently, just because everything's trying to go back to like a new normal, just creating kind of an infographic on ways to ease into that. And with infographics, of course, you could share them widely through social media, but you can also print them off as posters and put them around. So that's my other recommendation, I would think. Just create resources in that way.
Yeah, those are great recommendations. And I like what Bobby Joe was saying as well about the lifeguard app. Like, I think that's another really easy one for people to recommend to clients. Another one too, I'll pop in the chat here, is it's called the National Overdose Response Line, I believe, or service. But it's a phone number that people can call rather than an app, sort of similar to lifeguards, like Bobby Joe was talking about there. So those are a few good options. Did any of the other panelists have some practical strategies kind of to offer in terms of how to support people in rural and remote communities?
Yeah, I have one thing that I could add to that. Certainly the resources that have been talked about are critically important. How to get that access to the care that's needed, often just providing information on how and where to access is critically important. But I'd like to provide also a shout out to the work that's being done on the mental health first aid course that is available to communities. You can take it individually, or what we did here in Princeton is we organized it through the Princeton Community Health Table. We got some local funding to help us and paid for all 15 of our participants. And we're hoping that we can increase that. So if you're not aware of the mental health first aid course, then I would encourage you to take a look at their website. I'll find the website and put it into the chat, but a very worthwhile way to deal with individual situations that develop in the community. It's a huge resource that our community now has available to us, and I encourage others to look at that.
Yeah, that's a great point, Ed. I think organizing that for the community just to increase capacity and provide people with that education was a really great opportunity. So something to think about for other rural and remote communities out here, and if there's folks who can help organize that. The one other question we had in our Q&A here was just about internet access. And I see another question has popped up. And if any of our panelists want to type an answer to these questions, feel free. But we have about 30 seconds to try and answer this first one, which says, the shift to more virtual care does help address some of the transportation-related challenges. However, internet access remains an issue. Have there been efforts to investigate creating partnerships with for-profit industries that may help to provide internet services such as Starlink to help make internet more accessible and affordable for marginalized groups? So I'll just quickly throw that out to our panelists. Has anyone heard of that, worked with that? Bobby, Joe, or Ed, maybe, if either of you have attempted that? Well,
not actually directly. and the anonymous attendee that wrote this, you're absolutely right. The internet access does remain an issue in rural and remote areas of the country, as I mentioned in my presentation. And this is also compounded by the fact that a lot of people lack the hardware, especially people in vulnerable populations. If you don't have a computer or a laptop or whatever to be able to get to access the internet in the first place, that's a serious problem. I'm not aware personally of any efforts to create partnerships with for-profit internet companies such as Starlink. I know there are a lot of different companies out there that offer these kinds of services, but and it's possible that this is being done by others. I don't know how many people saw it, but yesterday the BC and federal governments announced that they will be funding a program to provide high-speed internet to all areas of BC by 2027. So, I mean, that's the kind of thing that needs to happen. Whether Starlink is going to be directly involved or not, I don't know, but certainly a commitment by both provincial governments and federal governments to make these kinds of guarantees and make sure that these things happen are critically important. And I think Nellie will be sharing links to this information in the chat box. So anyway, it's, as she points out in the chat, internet access has become a social determinant of health.
Yeah, absolutely. Thank you, Ed. And it looks like Nellie put the link in there in the chat. So we do have to wrap up here, unfortunately. So I'm sorry, folks, we don't have time for more questions. I see the other one was about the impact of recovery for people living in small communities. And I think one last quick comment on that would just be, I know from our work in rural and remote communities that it is very difficult for folks to access resources, as you know, each of our presenters talked about today in rural and remote communities. And when people are struggling with a mental health concern and you are living in a community where there's a lot of visibility, I know there's concerns around increased stigma, or I remember someone sharing with me once, you know, Alcoholics Anonymous or programs like that aren't really anonymous when everybody knows the one place and the one time that happens in that community that week. So we definitely have to think creatively about the way that we are supporting people in rural and remote communities. And I think that each of our panelists today did an amazing job of really highlighting different creative ways to do that. So thank you again to all of our panelists and for everyone who was able to attend today. I think this is a really important topic that I hope has just sort of kickstarted new conversations for you, helped you think about new ways to support people or to engage with your community, increase capacity. I think it definitely highlighted a lot of important things. So if folks can just remember, this recording will be available on the Mental Health Commission of Canada's website. You can head over there to watch, to share with other folks you think might benefit from this, and I hope that we can keep the conversation going. So thank you so much.